Welcome to this episode of Ask Me Anything, where I take your questions and I find the answers. And we are joined today by our medical correspondent, Dr. Tracy Weisberg from the New England Cancer Specialist in the state of Maine. I should say that's where I took a lot of my treatment, and she's one of my wonderful oncologists. Tracy, it's good to have you with us.
Hi, Joan. Good to be with you, too.
Absolutely. We're going to take a couple questions today. The first one comes from I am Darlene Cat. That's how it reads. Hi, Joan. I've been off chemo for 6 weeks now. I have triple-negative breast cancer. I'm waiting for my surgery date. I'm going to get a mastectomy. My question is it normal to have severe muscle pain 6 weeks after chemo ends? I called the cancer center and they told me to take Tylenol and that it is normal. I'm just worried that the cancer is spreading. Thank you, Darlene. What do you say?
So I have women asking me these questions every day, and most of the time this type of muscle pain and ache is a consequence of the chemo that they got. Usually we're using drugs like Taxol and adriamycin and carboplatin, and especially the Taxol can leave some people with muscle pain and sometimes numbness in their fingers and toes. But there might be some easy fixes here. So if Darlene Cat had a lot of issues in her blood, or maybe a lot of nausea and vomiting during her chemo, or loose bowel movements, maybe her electrolytes are a little bit off, and if she's depleted in potassium and magnesium, that can give you muscle cramps, and so that might be, and muscle pain too. She didn't say she had cramps. So maybe as a first measure of reassurance, maybe check that that's right, because that can be fixed if she's limited her diet in some way, or just had a rough time with chemo and a little bit on the malnourished side. And in triple-negative breast cancer, I mean, the fear is that some women with triple-negative breast cancer can have rapid recurrences, and for peace of mind for this woman, it probably wouldn't hurt to get a bone scan done. Do I think that she has spread of her cancer? Absolutely not. But sometimes you just have to prove it to people so that they can move. So those would be my suggestions. I think that as oncologists, we order a lot of scans, and some of them are peace of mind scans. But then you have peace of mind, and you have to put yourself in the position of that woman, and she knows what she's worried about. And why not just take that worry away?
And remember, when I came off Taxol and carboplatin, my hemoglobin and my red blood cell count and my white blood cell count, it was all so low.
Right.
I had a blood transfusion, and in fact, I had a second blood transfusion because it was just so low, and I just felt so lackluster and achy and almost flu-like. And those blood transfusions help. So I'm sure her doctors are watching that, but I mean, we really watched my hemoglobin and my hematocrit and those blood cell counts closely. And when they got down too terribly low, we didn't just let me suffer. We got me a blood transfusion, and I must say, I didn't get up and dance out of the hospital, but it does make you significantly stronger again.
Right, agreed.
All right, so we also have one from Patricia, 32. All right, Patricia says, I'm 67 years old. I'm diagnosed with infiltrating ductal carcinoma stage 2. She got diagnosed this last December. She had a biopsy, an MRI. She had a lumpectomy in February on the left breast. I was told I had slow growth cancer that chemo doesn't really work on, so I had radiation only. I completed it the end of May. Now I'm to start taking Tamoxifen, but with all the side effects, dizziness, increased risk of uterine cancer, stroke, blood clots, I'm not really sure if it's worth taking. Any advice would be helpful.
Okay, well, so there's a lot to talk about there.
Okay.
So Patricia, 32, she had an estrogen-driven breast cancer, not triple negative,
Right.
and so what usually happens is when you look at the pathology, when you look at what the tumor looks like under the microscope, the pathologist will make some declaration as to whether this is a slow-growing cancer or a more rapidly growing cancer. That's the grade of the tumor. Grade 1 is slow, grade 3 is fast. And some labs do a special stain called a proliferation index. Some call it MIB1, that's MIB-1. And if that's high, that means it's a more rapidly growing tumor. And if it's low, then it's a lower growing tumor. And then many women who have this estrogen-driven cancer have a special test done on their tumor called an Oncotype DX test.
I heard about that a lot. What is that?
Yeah, so an Oncotype DX test is also called the 21 gene score. And it is done right now by a company called Genomic Health. And it is a tool for assessing prognosis. But what it does is it takes the tumor out of the wax. The tumor gets put into wax in the pathology lab. So it takes the tumor out of the wax and it takes the RNA out of the tumor and it reverses it to DNA. And from the DNA, then they do an assessment of 21 different genes that scientists have established are important in how virulent or how aggressive a breast cancer is. And actually, in all, I think 4 or 5 of those genes are controlled, and just for comparing normal tissue. So they look at these genes and they come up with a score, and women get a score that is either low risk, intermediate risk, or high risk. And women who have low risk scores, there's some quite elegant studies that have shown that taking an estrogen blocker, endocrine therapy, is the best treatment. That because their tumor is dividing so slowly and that their risk of breast cancer metastasizing quickly, that the pills, the tamoxifen, is the best treatment. And because their tumor is dividing slowly, that chemotherapy would not really be able to kill their tumor. Does that make sense?
It does. I was kind of taken by what she said, that it's an increased risk of uterine cancer.
Yeah.
Like get rid of the breast cancer and now it gives you a risk of the uterine cancer.
Yeah. So my first long-winded answer to this question is that I suspect that this woman has had some kind of assessment of how rapidly her tumors are growing, and she's been told she doesn't need chemo, which is exactly state of the art, and that they've recommended that the best treatment, the best mouse trap for this mouse is to do an estrogen blocking treatment. And so now she's started on tamoxifen, which is an excellent drug, and 50 or 60 years old. It's a very interesting drug. It's kind of like the penicillin of breast cancer. Tamoxifen single-handedly around the world is responsible for elevating the cure rate of breast cancer. So it's a very, very important therapy, but it does have side effects. So because it blocks estrogen, it can give women hot flashes, it can give them dry skin. Some women get vaginal dryness and have some difficulty because of that, have difficulty with intercourse. Some women can get some leg cramps. And the fatal flaw, which really I think has been kind of, over publicized, is this little itsy bitsy risk of it causing uterine cancer. So the rate of uterine cancer in the general population is about 3 per 1,000 women. And on tamoxifen, it is exactly doubled. It's about 6 per 1,000 women. So there is a tiny risk of it causing uterine cancer. Having said that, it is an absolutely awesome, perfect option for any woman who's had her uterus out, because then you don't have that risk. The aromatase inhibitors, the other class of anti-estrogen therapy, do not have a side effect of uterine cancer. And that's one of the few reasons why they are preferred over tamoxifen. So that might be an option for her.
Yes, it sounds like if this is like such a concern of hers, again, for peace of mind, because that's important in all of us who have all these concerns about fear of recurrence or anything else,
right,
fear of spreading, that if there is something else that is a possibility for her to take, then she should talk to her doctors about taking one of those.
Right. And then her other concern of the blood, yes, this is a little dirty secret that I don't think that we fully appreciated until the last 10 years or so, but any type of hormone therapy like birth control pills and hormone replacement therapy and tamoxifen have a higher rate of causing blood clots. And the person that is at higher risk for having a blood clot is someone who actively is smoking cigarettes, someone who has really, kind of significant varicose veins, and someone who has a family history of clotting. And some people know that, and some people even know that they have a thing called factor V Leiden in their family, and people have clotted. So, right off the top, we try to eliminate giving tamoxifen to women who are active smokers and have any of these other risk factors. Also, if you are someone who sits a lot and doesn't move, that's a risk factor for clotting. So all of this comes into play. But at the end of the day, yes, I have absolutely had patients who have had blood clots. I have absolutely had patients who have had uterine or endometrial cancer, but they are in the minority. And the potential benefits that tamoxifen would do for her, cancer preventing a cancer in a distant site, or help reduce the risk of getting a breast cancer in the other breast, usually would be so much more benefit than risk, is what I'm saying.
Absolutely. All fantastic advice, Doctor. Thank you so much.
You're welcome, Joan.